Good afternoon. This is Nancy Archibald from the Integrated Care Resource Center, or ICRC. Thank you all for joining us today for Medicare and Medicaid nursing facility benefits, the basics and options for improved coordination and quality. Next slide. Before we get started, I'd like to quickly go over a few logistics. For those of you joining by phone, you can view the slides by logging into Zoom. You'll find the directions for doing that in the appointment for today's webinar. As usual, we will be recording this call so that you can revisit today's presentation or share the recording with colleagues who are unable to join. We'll send you a link to that recording and the slide deck later this week. To eliminate background noise, the phone lines are being muted for today's presentation. We will have a Q&A segment at the end of the webinar, but we'll use the Zoom Q&A feature, which is located at the bottom of your screen. And you can submit your questions at any point during the webinar. You'll also notice that we are using Zoom's live transcript feature to provide closed captioning of the presentation. If you would like to hide the captions, you can do so by clicking the live transcript icon, which is at the bottom of your screen, and then select hide subtitle. As you leave the webinar, a short evaluation will pop up on your screen, and we'd appreciate it if you would just take a minute to share your feedback with us. Next slide. Today's webinar is part of ICRC's Working with Medicare webinar series, which is designed to help state Medicaid agency staff learn more about the Medicare program and how to use that knowledge as they work to improve coordination of Medicare and Medicaid benefits for individuals who are eligible for both programs. The other webinars in this series include Medicare 101 and 201, coordination of Medicare and Medicaid behavioral health benefits, and state contracting with dual eligible special needs plans, which are also known as DSNPs. The recordings and slides from these webinars are archived on our website along with other ICRC resources, briefs, and e-alerts. And you can sign up for notices about upcoming webinars or new resources we publish by going to the link on this slide. Next slide. During today's webinar, we'll provide some background on Medicare and Medicaid spending on long-term care for dually eligible populations. And we'll explain how nursing facility benefits are covered by Medicare and Medicaid. We'll also talk a little bit about the characteristics of both nursing facilities and nursing facility residents, and review some basics about how Medicare skilled nursing facilities and Medicaid nursing facilities are paid under the fee-for-service system. And then we'll talk about some state options to improve coordination and quality of care in nursing facilities and ways to expand access to home and community-based alternatives. That's kind of a lot to cover, but we hope that there will be some time for questions and discussion following the presentations. Next slide. Our speakers for today are Amy Hoffmaster, Program Officer at the Center for Healthcare Strategies, Alicia Lomas, Research Analyst at Mathematica, and Molly Knowles, who is a Senior Program Officer at CHCS. Next slide. So before we dive in, I wanted to spend just a minute providing some framing or context for today's presentation. So as you probably know, full benefit dually eligible individuals qualify for both Medicare and Medicaid. That means they are eligible for Medicare because they are age 65 or older, or because they're younger than 65 but have a permanent disability, or they've been diagnosed with end-stage renal disease. Then on the right-hand side of the slide here, they qualify for Medicaid because they meet income and eligibility criteria, and those vary by state. Next slide. dually eligible individuals typically have chronic conditions and social risk factors. As a group, they often have significant long-term care needs, and they make up a high proportion of nursing facility residents. Over the last 18 months or so, we've really seen COVID-19 sweep through nursing facilities. In the United States, almost 1/3 of all deaths from COVID-19 have been among institutional residents. Next slide. CMS and other federal agencies have developed resources for both states and providers to control the spread of COVID-19 infection in nursing facilities and boost vaccination rates among both residents and staff. And today we're going to focus on steps that states can take to improve the quality of care and coordination of care in nursing facilities, and also the options that states have to meet the long-term care needs of dually eligible individuals in community-based settings rather than in facilities. So with that, I'm going to turn it over to Amy to begin our presentation. Amy?
Thank you so much, Nancy. And good afternoon, everyone. Our first primary section for today's webinar will be covering the basics of Medicare and Medicaid spending on dually eligible individuals. So let's dive in. Next slide. Dually eligible individuals account for a disproportionate share of spending in both the Medicare and Medicaid programs. In the Medicare program, dually eligible individuals are 20% of total beneficiaries, but account for 34% of total Medicare spending. And in the Medicaid program, dually eligible individuals are 15% of total beneficiaries, but account for 32% of total Medicaid spending. And one thing to note is that while the last time this data was gathered collectively for both Medicare and Medicaid was in 2013, more recent reports from Medicare and Medicaid separately show that these trends have continued in recent years. So this data is still pretty well applicable today. Next slide. So we can drill down to get a better understanding of what those total expenditures represent in terms of the services that dually eligible individuals are using in the Medicare and Medicaid programs. So in Medicare, the biggest spending items are inpatient hospital and outpatient services, but it's important to note that an average of $18,000 is spent annually for each dually eligible individual in skilled nursing facilities. And in Medicaid, the institutional long-term services and supports account for 49% of total spending, which amounts to nearly $42,000 of spending annually per dually eligible individual. Next slide. So following the thread of this very large amount of annual spending on institutional long-term services and supports for both Medicare and Medicaid, we can look further into the sources of payment to nursing facilities. In 2019, payments to nursing facilities totaled nearly $173 billion, and Medicare and Medicaid accounted for more than half of all those payments. And important to note is that Medicaid is the predominant payer of nursing facility services, and nationally, Medicaid covers over 60% of nursing facility residents. Next slide. And it's important to note that nursing facilities remain an important source of long-term care for Medicaid beneficiaries, even with recent rebalancing efforts to shift away from institutional settings and more towards home and community-based services. So on this map here, you can see that the states that are shaded darkest green have more than half of their total Medicaid long-term services and supports spending expenditures going towards nursing facilities. And looking closer, 22 states have nursing facility expenditures that account for 48% or more of total Medicaid LTSS spending. Next slide. So just as a quick recap of the highlights of the past few slides that we just went through, here's a couple of key takeaways describing those Medicare and Medicaid spending on dually eligible individuals. The first is that dually eligible individuals account for a disproportionate share of Medicare and Medicaid spending. Medicare and Medicaid account for 51% of all payments to nursing facilities. Medicaid is the predominant payer of nursing facility services and nationally covers 60% of nursing facility residents. Nursing facilities remain an important source of long-term care for Medicaid beneficiaries, even amid rebalancing efforts towards home and community-based services. Next slide, please. Now, the next section will zoom in on the nursing facility benefits that are covered under Medicare and Medicaid. Next slide. Medicare coverage of skilled nursing facility care includes short-term skilled nursing care and rehabilitation services. And it's important to make a distinction between skilled and custodial care. And to be covered by Medicare, a nursing facility stay must include nursing care and/or physical, occupational, or speech therapy. And without those needs, the stay will not be covered. Additionally, a 3-day inpatient hospital stay is required in fee-for-service Medicare. But one important thing to note, especially given the context that Nancy brought up earlier, is that this 3-day inpatient stay requirement has been waived during the COVID-19 public health emergency. And it's also worth noting that Medicare Advantage plans can waive that 3-day requirement as well in their benefit package plans. And the final point is that these services are ordered by a physician and can cover skilled nursing, rehabilitation, medical, social services, drugs, biologicals, durable medical equipment, and bed and board. And in 2019, CMS implemented a new payment model for Medicare payments. This is the patient-driven payment model, and it's based on an individual's medical conditions and functional status rather than therapy needs. And Alicia will talk about this more in depth later on in the presentation. Next slide. And Medicaid coverage of nursing facility care is for long-term custodial care. And I want to emphasize that Medicaid does not have the skilled care requirements that Medicare does. And the level of care criteria includes limitations in activities of daily living or instrumental activities of daily living, cognitive capacity, and need for supervision. This Medicaid coverage is a safety net for people who cannot afford the cost of nursing facility care. And Medicaid spend down is a process in which many people who otherwise would not qualify for Medicaid coverage end up spending down their income and assets to cover the cost of nursing facility care, and therefore end up becoming dually eligible through that pathway. And nursing facility care is a mandatory service for those ages 21 and up, and is optional for those under age 21. Medicaid coverage includes room and board, skilled nursing care and related services, rehabilitation, and health-related care. State Medicaid programs can provide optional coverage of therapies such as physical therapy, occupational therapy, speech pathology, and audiology services. Next slide. The responsibility for nursing facility costs varies in Medicare and Medicaid. In Medicare, days 1 through 20 are fully covered, and days 21 through 100 for a skilled nursing facility stay cost the individual $185.50 per day. Now, Medicare Advantage plans must cover the full 100-day period, but they can use a different cost-sharing structure for days 21 through 100 if they want. In Medicaid, all income is applied to the cost of care. And there are also special rules applying to community spouses, which are called prevention of impoverishment protections. And they enable couples to maintain a certain amount of income and assets for the community spouse. These costs are covered by different payers. Medicaid pays the Medicare cost sharing fee of $185.50 per day for most dually eligible individuals. And other payers might include retiree insurance or other supplemental coverage. Next slide. And here is a quick recap of the key takeaways on this section describing nursing facility benefits under Medicare and Medicaid. Medicare covers short-term skilled nursing facility stays up to 100 days when an individual needs skilled nursing and/or rehabilitation services. Medicaid coverage of nursing facilities includes long-term custodial care and serves as a safety net for people who cannot afford the cost of nursing facility care. The program and eligibility criteria for nursing facility coverage differ for Medicare and Medicaid. A beneficiary's financial cost-sharing responsibilities differ by Medicare and Medicaid. Medicare beneficiaries are responsible for $185.50 per day for days 21 through 100 of a skilled nursing facility stay. And Medicaid pays the Medicare cost sharing for most dually eligible individuals. And now I'm going to turn it over to Alicia to continue the rest of the presentation.
Wonderful. Thank you so much, Amy. Hello, everyone. My name is Alicia Lomas, and I am going to go over the characteristics of nursing facilities and their residents in this section of the webinar. Next slide, please. Okay, so this slide talks about the characteristics of Medicare certified nursing facilities. While this data we're presenting on this slide is for Medicare skilled nursing facilities, over 90% of SNFs are also certified as Medicaid nursing facilities. So a lot of the information here is also true for facilities that treat both Medicare and Medicaid patients. And this is just because the requirements for participation as a Medicare nursing facility are often identical to Medicaid requirements. The second bullet here says that slightly under 15,000 Medicare certified facilities in the country, and that there are about 100 beds per facility. So they're quite large, these facilities. About 70% of nursing facilities are for-profit, 23% are non-for-profit, and 6% are operated by the government. And almost all Medicare certified facilities are freestanding at 96%, which just means that they are not attached to a hospital. Most of these facilities provide both Medicare SNF beds and Medicaid custodial nursing facility beds. And in general, there are only a limited number of Medicare SNF patients on a given day, and the vast majority of patients are Medicaid long-term custodial care patients. So typically, Medicare SNF patients are there for a much shorter time frame, but have a higher reimbursement rate per day than Medicaid patients who reside in the facility for a much longer period of time. Now, this last piece of this slide here says that there is almost about 4% of facilities that are hospital-based, which just means that there are beds in a hospital dedicated to SNF patients. And lastly, in some rural hospitals, there's something called swing beds. And swing beds are sometimes used for long-term custodial patients through Medicaid, but there's also the same bed used for Medicare SNF services. Okay, next slide, please. Great. So here we're going to review the slight decline of about 0.7% of Medicaid certified nursing facilities in the country. So this decline occurred between 2019 and 2020. And there are a number of factors that really could be influencing this decline. For example, one may be the lower payment rates by Medicare Advantage plans and their lower use of these nursing facilities. The decline in count of Medicaid certified nursing facilities may also reflect the expansion of home and community-based waiver services, which, as we know, is an ongoing federal priority. And the expansion of these HCBS services strongly continues today. So we see these last two bullet points. There are two recent initiatives. One includes funding to help with states with the Money Follows the Person demonstration program. And the last bullet is about the American Rescue Plan Act of 2021. And we're going to be discussing more about HCBS and nursing facilities later on in this presentation. Next slide, please. Great. Okay, so here is an overview of the characteristics of the residents in Medicare and Medicaid certified facilities. Most nursing facility residents are over the age of 65 years old, which makes sense. Only 16% of residents are younger than 65 years old, and 42% are 85 or older. The majority of residents are women at 66%, and the majority are white at 78%. Now, 78% is pretty notable, and that's because it shows far less racial diversity than in the duly eligible population as a whole. Okay, so the figure to the right here shows the percentage of nursing facility residents with activity of daily living impairments, or ADLs. ADLs are routine daily activities like dressing, eating, bathing. And you can see here in the graph, 63% of patients have 4 to 5 limitations in their ability to complete routine activities of daily living. And 20% actually have no limitations. Now, this 20% who do not have limitations are actually those in the facility due to a Medicare SNF stay after a hospitalization, or those in a nursing facility who have cognitive impairments and need supervision. The last few bullets on this slide just show the varying degrees of cognitive impairments of those who have them. Next slide, please. Okay, great. So this slide provides common scenarios of how individuals with Medicare and Medicaid enter a nursing facility. I'm not going to go through each bullet point, but in summary, the primary way to enter a Medicare nursing facility stay is through first experiencing that acute episode of care, which results in a consecutive 3-day inpatient stay. And then on the right-hand side of the screen, we see that a main way to get into a Medicaid nursing facility stay is through, of course, needing to meet the nursing facility level of care standard, which does vary by state, and then meeting the state asset and income guidelines. And a common way to transition into a Medicaid nursing facility stay is from either receiving HCBS services or from transitioning from a Medicare SNF stay. Okay, next slide. Key takeaways. So to review this portion of the webinar, most nursing facilities do participate in both Medicare and Medicaid. They're freestanding and most are for-profit facilities. Key nursing facility statistics show that 66% of residents are women, 78% are white, and 42% are age 85 and older. And a common theme throughout the webinar is also that states continue to expand home and community-based waiver services, which allows individuals to be remaining in their home instead of being admitted into a Medicaid nursing facility. Now, the doorway to Medicare SNF stay begins with what I said, an acute episode resulting in a 3-day inpatient stay of the hospital. And a common doorway to a Medicaid nursing facility begins with, unfortunately, people spending down their income and assets to meet the Medicaid eligibility requirements. And they're commonly transferred into a Medicaid facility from either receiving HCBS services or after a Medicare SNF stay. Next slide, please. Okay, so this section of the webinar is going to focus on Medicare and Medicaid fee-for-service payment systems for nursing facility services. Next slide. So why is it important here to understand fee-for-service Medicare and Medicaid facility payment systems? It's because Medicaid MCOs and Medicare Advantage D-SNPs usually use fee-for-service nursing facility and Medicare SNF rates as their starting point for their payment to these facilities in their provider networks. So it's important to take all of this into consideration when designing integrated care programs for duly eligible individuals. Now, of course, plans may pay slightly more or less than fee-for-service rates, but the structure of the payment is usually similar. So being aware of these payment basics helps to assess managed care network adequacy and manage care plan relationships with SNF and nursing facility providers. Next slide, please. Okay, so a lot going on this slide. This slide is reviewing the fee-for-service Medicare payments to SNF facilities and the recent changes that took place to this payment system in 2019. Medicare uses a payment system for skilled nursing facility coverage through which daily per diem rates are paid to skilled nursing facilities. Payments to skilled nursing facilities are determined by calculating base rates separately for urban and rural areas, like we are seeing on the left-hand side of this slide. And now those base rates are updated on an annual basis using what is known as the Skilled Nursing Facility Market Basket Index. And now the change came in 2019. So Medicare base rates changed to include the sum of 6 components of care, which I will go into detail on the next slide. And Medicare makes adjustments to each of these 6 components of care to account for geographic differences in labor costs. And in addition, payments for 3 components, which are physical therapy, occupational therapy, and non-therapy ancillary services, are now adjusted for the day of stay, with higher payments to the SNF for care provided during earlier days in this stay. Now, the goal of this payment redesign that occurred in 2019 was to address concerns that the previous payment system, known as the Resource Utilization Group, or RUGS, was based on volume of therapy services provided, which created inappropriate financial incentives. So this redesign meant to shift payments away from volume of therapy provided and is now driven by the patient's clinical characteristics and need for care. Okay, next slide, please. Now, like I mentioned, this slide shows the 6 components of care that is driving the daily reimbursement rates for individuals in a Medicare SNF. Now, we add all of these 6 components together, and that is going to make the full payment rate. So we have nursing needs, physical therapy, occupational therapy, speech therapy, non-therapy ancillary services, and that room and board. So all of these are added up together to make that full payment rate. Next slide. Now we are shifting to Medicaid. So in the fee-for-service Medicaid, states must comply with broad federal guidelines, but are otherwise able to set up their own individual payment methods for nursing facilities. Most states use some form of daily per diem rate. However, state policies vary significantly in terms of rate components, adjustments, add-ons, and carve-outs. So like in Medicare, state Medicaid rates are often adjusted based on a variety of factors in order to ensure fair reimbursement or incentivize specific behaviors. Some states also make additional supplemental or incentive payments to certain facilities or for certain services. Medicaid per diem rates or components of those rates may also be calculated on a facility-specific basis, standardized statewide, or set based on peer groups, which is a method where facilities are grouped together based on common characteristics that are influencing costs. Okay, next slide. Now, as I mentioned in the previous slide, rate setting methodology does vary significantly state by state. So in this slide, we've included a table that highlights some different factors that are considered in Medicaid nursing facility payment systems throughout the US in 2019. This slide provides a picture of the wide variation that exists in state Medicaid nursing facility payment policies. And now if we look over to column 3 on this slide, the various Medicaid acuity-based payment systems are actually similar conceptually to the SNF PDPM system in that they are both based on measures of patient care needs. And now looking to column 4, the various state quality and performance-based payment systems are, again, conceptually similar to Medicare's skilled nursing facility value-based purchasing program. And as we see here, 25 states provided these incentives in 2019. Okay, next slide, please. Now, this slide provides a snapshot of recent trends in fee-for-service Medicaid payments to nursing facilities. While Medicare reimbursement for skilled nursing facility services remains significantly higher than Medicaid reimbursement rates, we do see recent Medicaid payment trends that states are actually increasing their payment rates to nursing facilities. So in 2020, and I want to note that this is before the public health emergency, 40 states plus DC increased their Medicaid nursing facility rates, and this was also the same case in 2019. Next slide, please. All right, so in summary, the key takeaways for this section of the webinar include that Medicaid MCOs and D-SNPs typically use nursing facility and SNF fee-for-service rates as their starting points in determining payments to their network providers. There was a patient-driven payment model implemented in 2019 that shifted payments away from away from volume of therapy provided in Medicare SNFs to the need for medically complex clients. And this payment model is similar to acuity-based case mix in Medicaid nursing facility payment systems. And lastly, in 2019, 25 states had Medicaid nursing facility performance-based payment incentives, and 40 states increased their nursing facility payment rates. Okay, so now I would like to turn it over to Molly to review state options to improve care coordination and quality in nursing facilities.
Thanks so much, Alicia. I'm Molly Knowles from the Center for Healthcare Strategies, and I'll first be discussing state options to consider when trying to improve coordination and quality of care in nursing facilities. Next slide, please. So state Medicaid programs are increasingly using managed care when trying to improve care coordination and quality for their long-term service and supports populations. In these programs, managed LTSS plans assume financial risk for the services included in their capitated rates and are also supposed to meet several state and federal requirements around service coordination and quality metrics for the delivery of those services, which includes nursing facility services. States can consider a variety of strategies when designing their nursing facility quality improvement initiatives, including streamlining data collection activities to reduce provider burdens and enlisting technical quality measurement experts who can then help states to develop accountability for their health plan quality. Quality initiatives in nursing facilities affect many stakeholders, and so outreach efforts during the design and implementation of these types of initiatives are important to ensure broad support. And also, states should consider potential unintended consequences of their quality improvement initiatives and try to take steps to prevent these types of consequences. Next slide, please. States and managed care plans are increasingly using value-based payment or VBP programs with their nursing facilities. I wanted to highlight that integrated Medicare and Medicaid approaches to a VBP program can have the potential to achieve more significant improvements than a separate payer initiatives because these integrated initiatives can reduce competing Medicare and Medicaid priorities. And as such, providers can then provide a more holistic approach to care with incentives that focus on improving care and quality overall, regardless of the source of payment. In 2017, the Integrated Care Resource Center interviewed several states and managed care plans about their VBP programs. And we've identified some important lessons for states interested in using VBP with their nursing facilities, which are noted here on this slide. Some of the most important lessons to consider include making sure that the payment incentives are large enough to motivate change among providers, trying to reduce provider reporting burdens by aligning reporting requirements, and also states should consider including a variety of stakeholders to be involved in the program design. Next slide, please. We've seen a variety of VBP approaches in different states. I won't go into too much detail about these approaches, other than to note that in some states, like Arizona, for example, the state will set baseline expectations for their managed care plans to use for the VBP programs with nursing facilities, but leave the specific details about the design and performance specifications to the plans themselves. as opposed to other states that have had a much more hands-on approach, like Minnesota, for example, where the state incorporates quality improvement goals into their contract provisions with the plans. Next slide, please. States can also consider several CMS programs that target quality in skilled nursing facilities. So for example, through the Medicare Skilled Nursing Facility Value-Based Purchasing Program, CMS awards skilled nursing facilities with incentive payments based on hospital readmissions. Recent legislation allows CMS to apply up to 9 additional measures to this program, and CMS recently offered several measures in a proposed rule that states could consider also for their Medicaid quality initiatives, including measures of functional status, patient safety, care coordination, or patient experience. Next slide, please. Additionally, CMS measures skilled nursing facility quality as part of its Nursing Home Compare website. So in this system, each nursing facility is given an overall rating of 1 to 5 stars based on performance across 3 domains, including health inspections, staffing, and a set of 24 quality measures. States can also consider using and comparing these CMS star ratings to their own state Medicaid quality measures for the same facilities. Next slide, please. And from 2012 to 2020, CMS partnered with enhanced care and coordination providers to implement an initiative that focused on reducing avoidable hospitalizations. States and health plans can also consider using similar approaches to reducing avoidable hospitalizations. And these approaches can be required or encouraged through contract requirements, performance incentives, and performance improvement projects with health plans. Several states have had VBP initiatives that work with health plans to target avoidable hospitalizations that have relied on similar measures and activities that were used in the CMS initiative. So for example, in Arizona, the Mercy Care Health Plan developed strategies that targeted urinary tract infections to reduce avoidable hospitalizations among nursing facility residents. And in Minnesota, health partners also are targeted reducing pressure ulcers as also a way to reduce avoidable hospitalizations. Next slide, please. Integrated care programs, for example, Medicare Medicaid plans under the financial demonstrations or DSNP-based models, can offer particular opportunities for states and health plans to target improvement of care coordination and quality for dually eligible nursing facility residents. With integrated care programs, states can use their state Medicaid agency contracts with the plans, for example, through their model of care requirements or provisions related to enrollee and provider communications to require plans to target coordination of care for their nursing facility enrollees. Integrated care plans focus on improved coordination can then result in improved quality for nursing facility residents, including the potential for such improvements as having Medicare skilled nursing facility and Medicaid skilled nursing facility benefits operate more seamlessly together for the enrollee, as well as the potential for improving care transitions between nursing facilities, hospitals, and the community. I also wanted to note that integrated care plans provide states the opportunity for additional oversight of nursing facilities by having plans partner with state long-term care ombudsman programs. Next slide, please. In addition to avoiding unnecessary cycling in and out of hospitals, states may also want to examine the rate at which dually eligible nursing facility residents are discharged involuntarily. States working with integrated care plans have opportunities to address concerns related to these types of discharges. So for example, states can include provisions in their contracts requiring the plans to address involuntary discharges, including in their model of care requirements. Plans can also provide additional oversight to the state surveillance of involuntary discharges, and these plans can offer coordinated responses, including identifying community housing and other alternative placements for the individual discharge. Next slide, please. In summary, states can consider a variety of strategies when designing their nursing facility quality improvement efforts within MLTSS programs. And as such, states and managed care plans are increasingly using value-based payment programs with their nursing facilities. Integrated care programs can offer particular opportunities for states and health plans to target improvement of care coordination and quality for dually eligible nursing facility residents, including targeting avoidable hospitalizations and alleviating challenges associated with involuntary discharges. Next slide, please. So in addition to opportunities to improve care coordination and quality for dually eligible nursing facility residents, states and health plans also have opportunities to identify and expand home and community-based alternatives to care in nursing facilities. Next slide, please. Although the Medicaid program has historically relied on institutional settings to provide long-term services and supports, federal and state policymakers have focused on rebalancing or shifting LTSS away from institutional settings and toward home and community-based services, or HCBS. And COVID-19 has really accelerated this federal and state interest to rebalance LTSS. Additionally, the federal government has recently supported state efforts for rebalancing through several initiatives and development of resources, as previously noted in this presentation. Next slide, please. States can consider a variety of strategies to increase HCBS, which are discussed in this toolkit linked at the bottom of the slide. These strategies can be bucketed into three main types of activities. One, developing LTSS system infrastructure to promote greater access to HCBS. And two, investing in programs and services that can help nursing facility residents return to and safely remain in their communities. And three, states can also consider expanding access to HCBS to a targeted group of pre-Medicaid individuals that could potentially slow their likely future need for more expensive institutional services. Next slide, please. So states with integrated care programs have particular opportunities to increase the use of HCBS as alternatives to nursing facility services. Integrated plans that cover both Medicare and Medicaid services have built-in financial incentives to reduce the use of costly institutional care, and they have the ability then to use Medicaid HCBS options to do so. I'll quickly note that institutional special need plans, or ISNPs, are plans that focus on Medicare skilled nursing facility and other Medicare benefits. They enroll both Medicare only and dually eligible beneficiaries. ISNPs are considered non-integrated Medicare only plans and therefore generally cannot take advantage of Medicaid HCBS options. If interested, ISNPs are described in further detail in the appendix to this presentation. On the other hand, states that work with integrated care plans can take advantage of these plans' incentives and abilities to increase the use of HCBS. So for example, states can structure their Medicaid capitated payments to the plans, as well as provide additional payment incentives to encourage HCBS. States can also include provisions in their contracts with plans to require plans to facilitate HCBS. For example, using model of care requirements that specifically require plans to coordinate discharge and transition planning. Next slide, please. States can also require plans to report quality measures that focus on the availability and use of HCBS among their enrollees. And with that, states can consider aligning these HCBS measures with the state's HCBS waiver specific terms and condition requirements, as well as other MLTSS program measures. States can also encourage plans' efforts to reach out to enrollees to make them more aware of Medicaid HCBS options. And states can also encourage plans to work with providers and have the plans help providers better understand integrated care models, train HCBS providers in managed care billing patterns, and also help promote faster HCBS provider contracting and credentialing. Next slide, please. So in summary, states have made progress towards rebalancing LTSS, and COVID-19 has really accelerated the state interests and efforts to promote HCBS over institutional services. Integrated care programs provide states key opportunities to expand the availability of HCBS options for dually eligible beneficiaries, primarily because these integrated care plans have both the financial incentives to reduce costly institutional care, as well as the ability to then use Medicaid HCBS options to do so. Thanks so much, and I will now turn it back to Nancy.
Great, thanks, Molly. That was really good. And Amy and Alicia, your presentations, I think, were really helpful as well. So let's turn now to some Q&A. And just as a reminder, please use the Q&A icon down at the bottom of your screen to type in your question. We had a few come in and were actually directly chatted to us as well. And I'm actually going to start with one for Molly. So the speaker mentioned I-SNPs very briefly, but said that they were not an integrated care model. Why would a state want to contract with an I-SNP? Can you address that one, Molly?
Sure, thanks, Nancy. So while it's true, I-SNPs only cover Medicare services used by nursing facility residents. So for example, inpatient hospitalizations, trips to the emergency room, and physician visits. There is no reason why a state and an I-SNP could not enter into an agreement. So where this I-SNP would then cover Medicaid services used by the residents, including the cost of nursing facility stay itself. And so then the I-SNP itself would become the single entity accountable for all of their enrollees' Medicare and Medicaid covered services.
Great, thank you. Yep, so let's see. So here's one, I think maybe Alicia, you had the payment section, so maybe we'll give this one to you. Payment for the 3 components are adjusted for the day of stay, with higher payments to the SNF for care provided during the earlier days in the stay. Which 3 components were these, and what do you mean by higher payments for the stay earlier days in the stay? Can you elaborate on that a little bit?
Oh, yes. Yeah, of course. Thank you. Okay, so the 3 components are physical therapy, occupational therapy, and non-therapy ancillary services. And so under this new Medicare SNF patient-driven payment model, the payments for physical therapy and occupational therapy are at a higher rate for the first 20 days of the stay, and then they slowly decrease for the later days of the stay. And then payments for the non-therapy ancillary services during the first 3 days of the stay are actually 3 times higher than those provided during later days. Now, the reason that these 3 services have higher payments during the earlier days in the stay is just to make up for the upfront nature of the cost at the beginning of one stay.
Got it. Thank you. That's very helpful. It's a whole new way for us to think about the payment rates. So we're going to have to get ourselves adjusted to that, and also it'd be interesting to see, you know, in coming years how that shakes out in terms of changing the landscape of payments. Maybe for Amy. So Amy, you had talked at one point about spend down and the spend down process for qualifying for Medicaid nursing facility coverage. Excuse me. So I wonder if you could just talk a little bit more about that. I know we have a lot of state Medicaid folks on the line that might be familiar for them, but there are a whole lot of other attendees out there too that may not be as familiar. So that might be helpful for them.
Sure. So that spend down process, what that means is the process by which a person with Medicare whose income is too high to qualify for Medicaid might still be able to get Medicaid coverage if their non-covered medical expenses or cost sharing, so things like premiums and deductibles, are more than their available income. So in this situation, most states allow a person to reduce their countable income by subtracting medical expenses and cost sharing from their income amount. So when subtracting medical expenses and cost sharing lowers a person's income to a level that qualifies them for Medicaid, this is the process that's called spend down. And states can choose to set spend down periods anywhere between 1 to 6 months. And so in a state with a 1 month spend down period, a person must spend down to that Medicaid limit each month to qualify for Medicaid that month.
Great. Thank you, Amy. That's helpful. You hear a lot about it, but often you don't really get that depth of explanation. Molly, I think maybe this one for you. What are some data sources that states could use for their quality improvement efforts with nursing facilities?
Sure. So Medicaid funded nursing facilities already collect a variety of data. So for example, the minimum data set, or MDS, is collected at regular intervals from all Medicare and Medicaid certified facilities. So states could consider using the MDS to monitor facility performance, and they could do that over time since it's collected at regular intervals. Although I do want to note that it's important to that existing data sources may not all support all of a state's quality improvement goals, such as improving beneficiary satisfaction or experience of care. So therefore, a state should also consider working with providers and other stakeholders to identify new data sources and also establish processes for collecting this type of new data. So in order to try to minimize the burden placed on providers.
Great, thanks, Molly. We had a question come in through the Q&A feature. Can you please share more about plans partnering with long-term care ombudsman? And we have on the line Carrie Graham, who is our Director of Long-Term Services and Supports here at the Center for Healthcare Strategies and on our ICRC staff. And I'm going to throw over to her to answer that question for us. Carrie?
Sure. Hi, can you hear me?
I can.
Oh, great. So that suggestion came out of an example that we saw in California. During its dual financial alignment demonstration, they developed Medicare Medicaid plans called CalMediConnect. And for the first time, those managed care plans were working with a clientele who was institutionalized in nursing homes. And so one of the strategies, and at least one of the plans, was to partner with the state long-term care ombudsman office. So every region has its own local long-term care ombudsman office that is responsible for overseeing the quality of care and assisting with mediation and complaints in nursing homes. And so what this health plan did was partner with the long-term care ombudsmen. They would conduct joint visits to facilities, meet their members in person. They would help, the long-term care ombudsman would help the CalMediConnect care coordinator review residents' charts, could identify areas where quality standards were not being met or where good quality care was happening, help members with complaints. And also a key piece was that they helped identify individuals in the facilities who wanted to transition into the community. And so then the plan could use its care management and transitions focus to help people transition to lower levels of care.
Great, thanks, Carrie. That's a good example. And while I've got you, I think I might ask you another question as well. We also have a question on what are approaches for states to get MDS data from nursing facilities? How can they get that data? Does it come directly from the facilities, or where would they get that from? And Carrie, if that's not something that you can answer, we can throw that to one of our other colleagues as well. Or you may be on mute, that could be too. All right, so Aaron, Jim, any thoughts on sources of MDS data?
Yeah, I can give it a shot. Typically in a state, that MDS data from the nursing facilities is reported to the public health agency in the state that's responsible for oversight of care and quality in nursing facilities. So the Medicaid agency could get that information directly from the public health agency, or depending on how things are structured in the state, the Medicaid agency just could require the nursing facilities to report that data to the Medicaid agency, because the Medicaid agency is a payer, and providers will typically do what payers ask them to do.
Thanks, Jim. Good advice. And so here's a question, and I think I'm going to ask this one of Erin Weir-Lockmani, who is at Mathematica and also director of the ICRC program. Erin, for states that do not have Medicaid long-term services and supports programs, are quality programs still required? So does the state Medicaid agency, are they required to have quality programs for nursing homes?
So, you know, from the standpoint of federal statute and regulations, within a managed care world, states are required to have quality strategies, which is probably what this person is referencing here. You know, if a state has an MLTSS program, the quality strategy in that state would need to address how the state is going to measure quality improvement among its managed care plans with regard to the delivery of those LTSS services. And there is not a quality strategy requirement on the fee-for-service side for states that deliver these programs through fee-for-service. However, there are many states that still implement a variety of different quality improvement initiatives from a fee-for-service model. You know, it is possible in a fee-for-service model to even move toward value-based payment, and some of the things that Molly talked about early in her section here today, those things do not necessarily require a state to have a managed care program, even though sometimes they can be easier to implement in managed care sectors. But additionally, you know, fee-for-service states have done things like nursing facility report cards that show how different facilities within the state are performing on particular quality measures that are selected by the state. So there are a number of ways to still drive that quality improvement, even without that federal quality strategy requirement looming at large. So I hope that's helpful. The answer is it's not required in the same way that it is in a managed care program, but you know, there still are a lot of steps that can be taken to monitor and try to drive improvement in that quality of care for the nursing facility residents.
Yeah, and Nancy, I would just note that in the 2017 ICRC technical assistance paper that's referenced, Indiana, I'm almost certain, was included there in the case studies, and their value-based purchasing program was in fact in a fee-for-service context. Nursing facilities were not included in managed care in Indiana at that point, and still are not.
Great. Thank you, Jim. So we are just about out of time. I would like to say thank you again to our presenters today. If you'd like to revisit today's webinar and see the slides, we're going to be posting a recording of the call and the presentation. Just a reminder, the website also has links to our past Working with Medicare webinars, issue briefs, and other TA documents. We hope that this has been valuable for you today. If you're logged into Zoom, when you exit, you'll see the survey pop up. If you take a minute and provide us your feedback, that would be great. Thank you all for joining us, and to our partners at CMS. Have a good rest of your afternoon. Bye-bye.